So we're just coming online now, I think. There is an ever so slight delay between yeah, okay, we're online. That's good. Well, welcome very. It is nice to have you. Ymke, maybe you could introduce yourself and your research to start with.
Yeah, thank you for inviting me to this podcast. My name is Ymke. I am 25 years old and I work as a PhD student at the Department of Sexual Health, Infectious Diseases and Environmental Health at the Public Health Service, South Limburg. And my PhD research is about chemsex among men who have sex with men, which we will discuss today.
Well, thank you very much. It's lovely to have you here. Maybe you could start by explaining what chemsex is and then how it impacts men who have sex with men.
Yeah, of course. Chemsex means the use of drugs before or during sex, and this term is mainly used to describe this behavior among men who have sex with men. It is difficult to define chemsex in one definition, as the popularity of drugs might vary per place and time area. In London, for example, chemsex is defined as the use of methadone, GHB, GBL, and crystal meth during sex, as these are the drugs that are most often used in a sexual context by MSM in the UK. But in the Netherlands, we see that ecstasy, MDMA, GHB, GBL, and ketamine are the most popular drugs to use in a sexual context. So we know that the drugs might vary per country, and therefore we consider local monitoring to be very important to educate healthcare professionals about the most popular drugs, their effects, and health risks. So one of the first research questions was whether chemsex was also prevalent outside large cities, such as London and Amsterdam, because these were the places where this behavior was most often described in literature. In Limburg, we assessed the prevalence of chemsex, and we see that 35% of men recruited at the STI clinic reported chemsex in the past 6 months. And this percentage was similar for men living in urban and men living in non-urban areas. And therefore, we concluded that chemsex is prevalent in large cities, but also outside large cities, and deserves equal attention in healthcare and research in both areas.
That's very interesting. You said there that that was the first thing that you looked at. Maybe you could continue to expand on what the rest of your research encompassed.
Yes, of course. So we looked at the public health risks of chemsex. So we know from the literature that chemsex was associated with an increased risk for sexually transmitted infections. And in our study, we also found that chemsex was associated with being diagnosed with an STI. 33% of men practicing chemsex were diagnosed with an STI compared to 12% in men not practicing chemsex. And in men using 3 or more different drugs in the past 6 months, the STI positivity rate was even 44%. So we confirmed this association between chemsex and being diagnosed with an STI, and especially polydrug use was a risk factor. One possible explanation for this association could be that people are influenced by drugs in their decision-making processes. People might make more risky choices while under the influence of drugs. And indeed, in our study, we also see that condomless sex was more common among men practicing chemsex. And chemsex was also associated with mental health harms such as depression, anxiety, and dependency. And we also looked at this in our study by looking at the experienced negative impact on one's daily life, because this is an indicator that is often used in mental health care for mental health issues. And in our study, 1 in 10 men reported a negative impact on their daily life. Examples of these negative experiences were dependency on drugs and acquired HIV infection. And it is very important that this group is recognized in healthcare and support or help is needed is offered when this is needed. But of course, we also looked at the positive experiences of men practicing chemsex and their motives, so that we also could tailor healthcare programs to their experiences, so that the message of health promotion strategies is better accepted by the target group. And we see that the most important reason was to increase sexual pleasure by increasing arousal, prolonging sex, and decreasing sexual inhibitions. And also the majority, 60%, noticed that chemsex did not have any impact on their daily life. And 1/3 reported that chemsex had a positive impact on their daily life. Examples of positive changes were enrichment of my sex life and feeling free and relaxed. So yeah, it has two sides. Some men experience only positive effects, but some other men might have some health risks which are important to recognize in healthcare.
And you seem like you've almost covered a large amount there, but where do you see the need to really take this forwards? What implications do you think this will have in terms of healthcare provision?
So I think it's important that in healthcare, healthcare professionals talk about chemsex to make men feel comfortable to talk about it, and that our regular sexual healthcare is offered to these men, so that we reach these men with regular STI testing, PrEP, for example, to help them to prevent STI transmission. And for the mental health part, I think it's important that at STI clinics we see a lot of this target group. So it's important that STI nurses also talk about how this is experienced in their daily life, and if there are problems, they could be referred to mental or addiction healthcare organizations.
You said just there that you obviously see a lot of these groups at healthcare provisions. Do you think that I think earlier you indicated that that was also where you saw your almost research group from? Do you think taking your research group from an area where you recognize a higher prevalence of it almost to a small extent biases the outcome, in as much as the numbers may be higher than in the general group of men who have sex with men?
Yeah, that's an interesting question. I think we see at the STI clinic indeed a bit a high risk group, but in a study in Amsterdam, it was noticed that chemsex was as high as in the STI clinic among men using online dating applications. So I think our percentage might be representative for a larger MSM group.
And did you look further into the use of online communication in any way during your research?
Yeah, so we see that chemsex is most often happening in the home setting, and men are using online dating applications to get these chemsex parties at home. So this might also offer an opportunity to reach men who are not seen at the STI clinic but might need sexual health care or support. Yeah.
That's very interesting. Thank you. And one question is kind of where do you want to take this further in the future? Where do you see, like, if you were given the ability to research in any field, where would you go with it?
Yeah, I think we already looked at a lot of aspects of chemsex. So we also asked the STI nurses whether they already discussed chemsex. We see that a lot of nurses already discuss it, but also have a high need in training in some aspects. For example, recognizing problematic chemsex and harm reduction strategies. So I think implementation of our research findings into healthcare practice is very important. Also because we know that the target group must feel comfortable to talk about it, and to realize this, tailored healthcare programs should be made for them. So we also would like to research this issue in other healthcare organizations, such as mental or addiction healthcare organizations. And if needed, that there will also be training for these healthcare professionals. And another point is that we would like to increase our reach of sexual health care to men who are currently not seen at the SCI clinic. We are making different efforts to increase this reach by offering PrEP, doing outreach activities, and we are also starting a project that is using peer testing. So this project is called Limbo for Zero and includes the spread of home sampling test kits among peers to increase HIV testing among men who are not aware of their HIV status.
I think that's a very interesting and broad impact you've got there. You must have really enjoyed having carried out that research over the past 4 or so years.
Yeah, it was nice to look at these different aspects and to highlight it from a public health perspective, but also look at the individual experiences and experiences of healthcare professionals.
And what brought you almost to carrying out your PhD in this topic?
Sorry?
What was your motivation for researching in this topic specifically?
So for my Master Health Education and Promotion, I did an internship at a regional addiction institution, and I looked at cannabis use among high school students, and this raised my interest in why it becomes problematic for some, and while it doesn't become problematic for others. And I also think that it's important to study health issues in minority groups, as everyone deserves an equal health, a good health.
I think that's interesting. And did your research therefore, because you just mentioned that how it becomes a problem for some and not for others, did you look into the almost length of use instead of just the how many people were using it in a recent period?
What do you mean exactly?
Oh, yeah, sorry, that's just me. Whether or not, for instance, certain people were using it for several years or extended periods of time repetitively.
Maybe it's good to mention that we asked about the experience impact, but when we asked about the need for professional counseling, we saw that this need for counseling was higher among men who engaged in chemsex more frequently, had no sex without drugs for a longer time, experienced a negative impact on their daily life, and had the intention to change their chemsex behaviors. So these might be indicators healthcare professionals could ask about to identify healthcare needs. So I think these, indeed, also the time that one engages in chemsex is important to ask about, because it might be fun for a while, but then it might become problematic. So it's important to keep monitoring this impact, I think.
Yes, I think by the sounds of it does. I mean, sorry, just thinking for words. Yeah, sorry. My brain has just gone blank.
It can happen.
Yeah. You've obviously taken a lot away from your research, by the sounds of it. What do you think is the single most important thing that you've taken away?
So I think our main conclusions are that chemsex is not only prevalent in large cities, but also outside of it, and that it's important to discuss in healthcare, and also in SCI clinics play an important role because men reported to prefer discussing chemsex at the SCI clinic. We also know from previous research that men feel comfortable to talk about these issues at sexual healthcare they are already attending. So SCI clinics could play an important role in talking about this, delivering sexual health care, and also health promotion strategies in the sense of safer drug use. and recognizing problematic chemsex and referring men to other healthcare organizations when needed. Um, and I think this is also feasible because nurses already talk about this. They also received a lot of training, but also they also indicated a need for training, and that's also why we created an information brochure on chemsex for Dutch STI clinics for the healthcare professionals working there, including topics that they would like to receive training in. So I can maybe show you the information brochure. So this was implemented in all Dutch STI clinics based on our research. And it was a co-creation between the Public Health Service, but also experts in the field of drug use and a specialized institution on chemsex.
I think that's some very interesting takeaways and obviously some almost immediately practical benefits of your research right there. Something that's kind of almost threaded through what you've said so far. Do you see a need for an almost more holistic approach to the treatment that men who have sex with men, especially those who have chemsex, receive?
Yeah, I think it's really important for this behavior that a multidisciplinary approach is taken, and we also try to do this in our research by asking experts in the field of drug use and the specialized organization on chemsex and also the target group themselves. It's really important that they are involved in both what are important research questions and what do we have to do with these research findings in healthcare. So yeah, we really took a multidisciplinary approach in this, and I think this is really important to keep doing.
I think that sounds very interesting. Maybe now, for our listeners at home, you could expand on the methodology you took, because I think you just touched a bit on it there, to answer all of these very important questions.
We started this research in 2017, and men who had sex with men were recruited at the STI clinic in Limburg first, and then we expanded the research to other STI clinics in the Netherlands. And we use questionnaires. And in these questionnaires, all kinds of questions were asked about sexual behavior, drug use during sex, needs for help, experiences, and these questionnaire data were linked to the STI clinic data. So this provided us a unique opportunity to also get the STI test results, for example, to look at the association between chemsex and STIs. And in making our research questions and developing the questionnaires, we work together with the people I mentioned.
I think that's really interesting. How quickly did it expand? Because you said it expanded. Did you recognize the need to broaden it out quickly, or was it always intended to be taken to an almost national level?
We started in Limburg to mainly look at whether chemsex is also prevalent outside large cities, but when looking at the healthcare needs of men practicing chemsex, it was interesting to look at this in different regions. So because this was not only a phenomenon in Limburg, but we had a good response on the questionnaire in Limburg because men coming to the STI clinic are willing to talk about it, and they were, I think, motivated by the STI nurses to fill in the questionnaire.
That's very good to hear. And you spoke about how there were differences between Amsterdam and London earlier. Did you notice that there were large differences between the regions that your research looked at?
I think in Limburg, for example, the use of GHB is a bit higher than in Amsterdam. But I think the prevalence of chemsex is comparable between Amsterdam and Limburg. But there are also some differences in drug types used. So I think really local monitoring of the drugs used is important. And it's also important to use a broad definition of chemsex in research and also in healthcare practice to not exclude people who might also have an increased risk for STIs, for example, or who might need support or help, so that you not exclude these people only based on the drugs they use. But yeah, local monitoring is important to inform healthcare professionals about the drugs, their effects, and health risks, I think.
And do you therefore, I mean, you spoke about the need for a local monitoring. Do you think there could be instances where there are quite large divergences between different regions in how you need to provide healthcare to those in the region?
If I understand your question, why do you mean like in Limburg, for example, GHB is higher, and we know that GHB is highly addictive, so it might be necessary to provide extra information on this, or
and also the variants in drugs will have different effects, both short term and long term, and may need different strategies to combat it.
I think there are some general harm reduction strategies because I think, for example, regular STI testing is always important, and also not combining specific drugs. Some combinations are more dangerous than others. For example, those strategies are always important, I think. But of course, it depends on the drug used, whether it's more addictive or not, or yeah.
And we're now kind of moving into to some extent, the later stages of the discussion. What do you think, if there are any, were the drawbacks to your research at the moment?
I think some extra qualitative research might also be nice to get more into the deeper indicators of problematic chemsex, I would say, because this would be relevant for mental health care programs, which I will say, like, for some it becomes problematic and for others not. But why exactly is this? I think these questionnaires were not really, how do I say it? These are not really the
They showed you
methods to get into the deeper factors why it becomes problematic for some.
They almost identified the problem without explaining the cause of it.
Yeah. So, but yeah, we would like to inform the healthcare, and I think we have some relevant indicators that we had, that we could measure in the questionnaire. So, yeah.
Would you maybe like to expand on those indicators?
That's what I said earlier. I think so. One informant indicated that they would like to talk to a professional about chemsex-related issues. The main topics were increasing self-control, safer drug use, and reducing the STI risk. And this need for professional counseling was higher among men who engaged in it frequently, so 2 times per month or more, had no sex without drugs for 3 months, experienced a negative impact on their daily life. So I think these are the indicators that might be relevant for healthcare. Yeah.
I think that's quite a interesting mix there, and a lot to almost move forwards with. What? Sorry, my brain has decided to stop working today. Obviously, it's a Friday, and my brain has gone weekend. Taking it forwards, obviously, it requires a large amount of information for those who are at risk, and you showed the pamphlet, which will hopefully assist a lot. What else do you think needs to be done to create awareness of the possible negative effects?
I think research in other healthcare organizations is really necessary. So in mental and addiction healthcare organizations, to assess whether knowledge about chemsex is sufficient, and also at general practitioners, So I think research in other healthcare organizations is important, and also increasing our reach to with our STI clinic to men who are currently not seen at the STI clinic. So these are things that should be done, I think.
And I mean, obviously, it's always portrayed as a larger problem within the men who have sex with men community. But do you think there's reason to believe that problems exist in other communities of people that have sex? And do you think there are different reasons for that, or?
Yeah, I think drug use during sex is not only among men who have sex with men. I think it's we studied drug use during sex among swingers, so heterosexual couples who have sex with other couples, and the prevalence of drug use during sex was as high as in men who have sex with men, and also the motivations for doing this were quite similar, although some other drug types were used. And we are also going to look at drug use during sex among young people, because these the health risks might be a bit different. For example, you can think about unwanted pregnancies, for example. So I think it's important to study it in different population groups to tailor healthcare to the different needs and health risks.
Well, thank you very much. Do you have anything else that you feel like our viewers at home may be interested to know?
I think we discussed a lot about my research, so
it's been very interesting, and thank you very much. I think based on my time, we're nearing the end, so I shall end it here.